Hello, everyone, and thank you for joining us again today. I am Emmanuel Ossai, lecturer in religion and politics in the Global South, here in the School of Global Affairs at Lancaster University. In the UK, I'm joined today. I'm very pleased, actually, that I am joined by Dr. Oge Williams, all the way from New York. I shall introduce our guest in just a few minutes from now. But just to say, that today we're discussing women and healing in Africa. And I'm very pleased to be doing this with Dr. Williams because she's an expert in this field, especially in terms of its historical side. And just to say that the topic is also of great importance because we'll be talking largely about Nigeria. This is a beautiful country, of course, as many of us would agree, but unfortunately, it's been described as having not very positive maternal health records, especially when compared to a variety of nations. So it is very relevant that we are considering this matter. We're looking at the present in a certain way. So we're also trying to think about the past, given that the present, we understand, is often shaped by the past. So we're thinking about the colonial period, especially the first half of the 20th century, but also in the post-independence period and the contemporary era as well. So Dr. Williams, who has joined us, is an associate professor in the Department of History at the University at Buffalo, New York, in the USA. And she received her PhD from the University of Texas at Austin, in the USA. And some of her core research interests, and she's done excellent work in these fields. So they include maternal health and reproduction, and midwifery and women's history, and a variety of others, of course. She's also written an excellent text, by the way. This is something that I'm reading at the moment. I apologize, Dr. Williams, that I haven't finished, and I hope I will do this as soon as possible. But this is a wonderful book. So it's titled Birth Politics, Colonial Power, Medical Pluralism, and Maternity in Nigeria. And it was published by Johns Hopkins University Press this year, actually. And this book combines historical and textual and ethnographic methods as well to demonstrate the politics of childbirth in colonial and post-colonial Nigeria. And it does this very excellently. So it considers how British colonial authorities and medical missionaries and traditional healers and a variety of other actors like international population control organizations, how they actually sought to control birth and related matters and motherhood in this period in Nigeria's history, in the 20th century, and even more currently. Our guest is also the co-founder of African Health Awareness Network. So this is an organization that promotes health awareness and health education and healthy lifestyle, and it's done this for a while. She's also writing a book at the moment about maternity deaths. This is not, unfortunately, a very positive topic, but this is a subject which, of course, has to be dealt with, and she's already dealing with it. So it is such a privilege to have this scholar join us today to discuss this matter. And I'm very much looking forward to the engagement, Dr. Williams. So thank you for joining us.
Thank you very much. Thank you for inviting me.
Yes. But I have a few questions, as you can imagine, but I think the right place for us to start would be the book that I'm talking about, that I'm, of course, praising, perhaps even in a manner which you did not expect because of how humble you are, but I think it's an excellent book. If you would like to tell us briefly what the book is about, I think that would be very helpful. So what is birth politics?
Birth politics is simply a history of childbirth in Nigeria. That's the simplified version of what it is. And I wrote this book particularly because because of the gap in that literature when it comes to maternal health care. Nigeria has a maternal healthcare crisis, maternal death crisis, but there's really no comprehensive literature talking about and discussing the history of childbirth, the various dynamics of how we got to where we are today. So what birth politics does is to provide that kind of background information that discusses or that brings us to a clear understanding of the contemporary. I begin the book with a discussion of traditional childbirth, what traditional midwifery, indigenous birthing systems in Nigeria look like. And because Nigeria is a very diverse country with multiple cultures, multiple ethnicities, I take my case study, I focus specifically on one ethnic group, the Igbo of Nigeria, especially because not just because of the culture, but especially because this is also the area where one of the most important maternity facilities in colonial Nigeria, established by the Church Missionary Society, begins in the late 19th, early 20th century in the form of what became Iyeno Hospital. So I begin the conversation with that. And then I get to the moment of colonialism, where colonial missionaries and the colonial government inserts themselves in the reproductive scene and introduces biomedical hospital care and the kinds of exchanges and the kinds of politics and intersections that play out. And from there, I move on to the moment in the 1920s, late 1920s and 1930s, when we have a new actor emerge in the scene, in the birthing landscape, or what I call birthscape in Nigeria, in the form of the faith homes, in the form of faith healing, how basically the foundation of faith healing gets laid in the country. And I move on then to this moment in the 50s, where international actors come into the mix. Nigeria is becoming independent or getting ready to become independent. And so the politics of birth begins to shift. The focus of the colonial government begins to shift. The focus of international groups begins to shift and begins to converge in Nigeria. So I talk about this and then move on to the moment in the 70s, 80s, 90s, where all of these birthing actors, all of these reproductive health actors converge together. And we have a plural system, sometimes contesting against each other, sometimes working with each other in play. And this is where the book ends, the whole idea of medical pluralism. And I do a contemporary discourse and analysis of how all that plays out today. So that's as brief as I can go with what the book is about.
That's wonderful. That's excellent work. This is actually part of what I saw in the book, what you've just described, but this is very good for our audience. So based on what you've just described and my own reading of the text as well. So would you say that this is accurate? So in the first half of the 20th century, or let's say in the early period of that century, the key actors within the Nigerian medical space, especially as it relates to women, would be traditional healers and the group you describe as faith homes, and then the colonial medical practitioners, and then some Western missionaries, as well as international organizations. But I think the international actors kind of came in much later. Is that accurate?
In many ways, yes. The faith home element, faith homes do not become strong, do not become prominent until later on as well. The 1950s, 1960s. So I wouldn't necessarily count them in the period that you're describing. But there is the traditional medicine practitioners, those were the primary I would say, because even at the time when colonialism was established, colonial medicine did not necessarily touch the lives of the majority of Nigerians. So it is the indigenous practitioners, the midwives and gynecologists, the bone setters, the traditional doctors, the diviners, the herbalists, who were the primary source of care in many parts of Nigeria. When we talk about traditional medicine practitioners, it's not just the traditional doctors or
Yes.
the diviners. That was a well-defined field with its own sort of experts. Bone setting was very prominent in the northern part of Nigeria, but also in the southern part of Nigeria. Among the Igbo, for instance, and the neighboring ethnic groups, bone setting was a very old and very well-established fields. And then there were always the traditional midwives, those who delivered babies, and the traditional doctors who specialized in gynecological ailments, those who intervened in the cases of fertility issues, when there were issues with conception, or when there were difficult deliveries, difficult circumstances, there were those traditional doctors who were experts and who would work alongside the traditional midwives in this case. And then the diviners, of course, we have an understanding of what the diviners were. That was the person you went to when the condition did not have any clear medical indication, or when the condition was quite uncertain, in the sense that it becomes difficult to say, well, this is caused by a natural factor, or this is a spiritual issue. The diviner is who then says to you, this is what's going on, and this is who you should see, or this is what you should do. And then there were the herbalists, those who were well known and well versed in their prescriptions, in knowledge of herbal medicine, the mixtures, the combinations, the things that you take to take care of yourself. Now, there were missionaries too, as that would be the second major primary actor when it comes to Nigeria's health sector in the early to mid 20th century. Missionaries, these were the main agents of biomedicine in Nigeria, not the colonial government actually, because for a while into the 1930s and then 1940s, the colonial government was not largely invested in the medical care of its population. It provided medical care largely to the European population in its colony and the growing working class in the urban areas. So all of the folks outside of the urban areas still had to do business as usual, right? They are traditional practitioners, but it was the missionaries who were building hospitals, setting up clinics, because they connected medicine with conversion.
Absolutely.
It was a tool of conversion, a tool of laying their roots in various communities. And so they believed, for instance, that if they provided medical care and it was successful, then the community would be more open to their messaging. And in the case of childbirth, childbirth was a particularly interesting sector for missionaries, because one of the things that the arguments that they made in their documents was that when you assist a woman in her hour of greatest need, which is labor and delivery and childbirth, then you have not just won over the woman, but you've immediately gained access to her community. Because this woman that you just delivered, first of all, now you have a foothold in her household. And we know that in most traditional Nigerian societies, during the period that we're discussing, women controlled the certain aspects of their homes. So in that case, now the missionaries do not just have access to the woman, they have access to her children. They have access to the other women and other people that were under her. So this was a strategy. Medicine for missionaries was not just a therapy and care and social services. It was actually a weapon of evangelism. In fact, they believed for children, in the case of childbirth again and young children, that their intervention during delivery meant that they could also baptize more children and claim these souls for their various missions. And there was some competition going on too between the two major missions, the Roman Catholic mission and the Church Missionary Society. And so, yes, giving out medicine and baptism begins to go hand in hand. So they will be what I would consider the second most important actor in Nigeria's health sector during this period. And then there was, of course, the colonial government. I've talked about how they did not center the healthcare of the colony, but mostly the largely European population. But in the 1940s, this begins to change, because this was a time, we're talking about the post-World War, Second World War period. This was a time where there was a lot of pressure on colonial governments, not just Britain. There was a lot of conversations on colonial rule, on colonization, on people's ability to self-rule, right? So during this moment, Britain begins to pursue various social services projects in order to gain the favor of the colonized, but also to make its government, its colonial administration more credible. And so they begin to expand hospitals. They begin to try to train doctors, train midwives, establish hospitals, partner with missionaries in the hospitals, the projects that missionaries actually had. So during this period, you now have partnerships where what used to be mission facilities was now co-owned and co-funded by missionaries and the government as well.
All right, I see. Interesting. Oh, that's interesting history, to be honest. I mean, there's a lot to talk about, a bit deeper, to be honest. But I think we're going to invite someone else perhaps later on, and if you're available, we might take the conversation a bit further. I mean, you've already talked about how the hospitals or medical services were tools of missionization as well. It's interesting because that also applies to education, isn't it? And a variety of other social services. So I think we might think about these other aspects in other episodes here at Africa Simplified. But just to continue with the topic and the important points you've already raised. So the faith homes, they emerge subsequently. And my question, and I guess this might be of interest to some others as well, is what are these faith homes, and why do you describe them as faith homes? I mean, this is a concept which is not entirely different from other concepts that I've seen, like faith healing and that kind of thing. But is that exactly what you're thinking about? And in terms of the extent to which the faith homes could be described as Christian, is there also some link, perhaps, with the pre-existing traditional religious practices and beliefs, for example? So generally, what are these faith homes? And yeah, that's the question I'm thinking about. And how did they emerge?
You are right. Faith homes are very Christian. So when you think about faith homes, what they practice essentially is faith healing. And that question about why I call them faith homes is a very good question. I call them faith homes not because I decided that this was what suits them. This was what I actually found on the ground and the name that they insisted that I call them. Because when I first approached these spaces, I was calling them maternity homes. Okay. And the pushback that I got, not once, not twice, we are faith homes or faith delivery homes. So this is what they consider themselves. So now let me talk about how this concept and this whole idea of faith homes emerged. There was a moment in the 1920s and 1930s, when the biomedical system, even the traditional medicine, could not successfully deal with the various diseases, epidemics, and pandemic that was going on at the time. So people began to move towards faith healing, towards prophets and prophetic movement to seek care. And so this was a moment when this movement begins that believes in faith healing, in prayers and divine intervention. And some churches form as a result of this movement. And the movement that I refer to in particular is the Aladura movement. Aladura means prayer people. It emerges in the late 1920s and the 1930s. And a lot of their leaders were preaching faith healing. They believe in an absolute reliance in God for healing and for deliverance, which made sense during the time period, especially because biomedicine, the hospitals had failed to protect the people. So a lot of people moved towards that. And what some of those leaders and prophets then began to preach was absolute reliance on faith healing. And when you have absolute reliance on faith healing for your members, well, there are women giving birth. Where do they go? They began to preach that using hospitals and using hospitals was a sign of a lack of faith. Using traditional medicine was idolatry. Going to the traditional practitioners was idolatry. It was a sin. And so you couldn't do that. So because of this kind of circumstance, well, they had to create the spaces themselves. These independent or indigenous African churches that emerged as a result of this movement had to create independent spaces, their own spaces where women could come to give birth. So this becomes what evolves into faith homes. Now, in the 30s and 40s, faith home was not a space exclusively dedicated to giving birth. It was the space where people who were seeking for healing, for deliverance, for prayers came to. This was where they came to get their dosage of prayers. This was where they came to get ministered to for their various problems. But for the Christ Apostolic Church, whose faith home I specifically look at in my book, in the 1950s, they transformed the faith home into an exclusive space where women give birth. So when I talk about faith home in my book, I'm talking about this religious space of childbirth that operates based on the concept of faith healing, where women, at least from the 1940s and 1950s, where women come to give birth. Because in the 1940s, CAC, which was the foremost Aladura church, African independent church at the time, CAC bans women in its constitution officially from going to the hospitals to deliver. And so the faith home equally transforms into this space where women came to get care for childbirth. And so this is a context in which I discuss faith homes. And again, the name faith home is not from me as a researcher, but from them, that what they call themselves, it is faith home and faith delivery home.
Yeah, I didn't know that. That's very helpful information, to be honest. And I'm just wondering if personally I also need to take seriously this aspect of self-description and self-viewing, because at times we describe, yes, and we ascribe these names and other concepts without actually taking into account how the population would prefer to be described themselves. So it is, yes. So the faith homes in present-day Nigeria, for example, would you say that they have evolved over time? Would you say there's been some improvement, for example, given what faith homes look like perhaps in the past 50 years and what they are today. And also perhaps not just in terms of the equipment they use or the services they render, but just in terms of how organized they are, and also perhaps how they partner with the states, for example, for the good of women.
That's a very loaded question. It has different elements to it.
It does.
Faith homes have they have certainly evolved, and I want to preface my answer by emphasizing that there are different kinds of faith homes, right? There are faith homes associated with other churches outside of CAC, and the ways that they organize, they're organized, the ways that they practice are different. There are cultural elements peculiar to the faith homes in Western Nigeria, which is predominant, which is Yoruba, right? There are cultural elements that are Yoruba that you see present in the faith homes there that you do not see and you may not see in the faith homes, say in Southeastern Nigeria. So a lot of my answers is going to center on the faith homes of the Christ Apostolic Church, CAC, because that's a very good example of how they've evolved over the years. So
that's especially in the Southwest.
Yes, that's okay. Especially in the Southwest. It's very big. It's very predominant in the Southwest. Okay. Earlier on during their existence, I talked about the 30s, 40s, 50s. The first belief, the first way that they practiced was faith healing, divine intervention, the belief in prayers. But even that became very methodical. Like to care for a woman, for instance, the woman had to come and register in the faith home that they want to have their babies there. And then they had to attend weekly prayer sessions. Okay. There were weekly prayer sessions that they had to attend. Faith clinic is a term that a lot of Nigerians might be familiar with. And then they had their bi-weekly prenatal visits, where every 2 weeks they come in for the antenatal or prenatal care. But there were the prayer meetings, and then there was the belief in the use of psalms, and this is where Yoruba culture comes in too. In traditional childbirth among the Yoruba and in Yoruba medicine in general, there is the belief in ofo, powerful words. Spoken words, the power of spoken words. And now in the faith homes, the Psalms, scriptures, especially the Psalms, replaces certain incantations during birth. So they use Psalms to demonstrate this power of spoken words. And then there's this use of water that persists till date. Blessed water. The fact that when you speak over water, in the case of the faith homes, when you pray over the water and you speak, you pray with certain psalms, this water becomes imbued with healing properties. And when taken, it has the power it has spiritual powers. It has the power to be a conduit for healing. So there is that. But a lot of, in the contemporary period, these beliefs are still there, but there's been a lot of changes in the ways that they approached healing. I mentioned that in the 40s, CAC in particular banned women giving birth in the hospitals, and they banned the use of medicine for their members. Yes. That has also shifted quite a bit in the attitude towards biomedicine, because back when this ban occurred, biomedicine wasn't that sophisticated. It wasn't as effective against a lot of the illnesses that was being dealt with, the medical conditions that were being dealt with in the area. But by the 90s, 80s, things has changed. The technology has changed too. And one of the things that pushed this change as well is the attention in the 1980s, the global attention as a result of the work of what used to be population control, eventually family planning organizations across the world, and also in Nigeria, the attention that they drew to the statistics on maternal deaths. And so this put pressure on a lot of these faith homes, on everybody, on traditional birth attendants, traditional midwives, on the hospitals, on basically the rates that were coming out, the records of maternal deaths that were coming out. So some of the changes that have now happened is the encouragement to use medical technology outside the church, to go do things like HIV tests, know your blood group, do the rhesus factor test, so that if you have if you are Rh positive or negative, then you know what to do. If you need the Rh injection, then you can go get it and have a safe pregnancy and all that. And then there's also blood pressure monitoring by these midwives in the faith homes themselves. And one of the important changes that happened in CAC faith homes in the late 50s and then 60s was the establishment of a structure, the imposition of a structure to the way that the faith homes operated. And I would say the faith delivery homes operated by creating a school, a midwifery school, where those women who wanted to practice as faith home midwives actually got training, and the length of their training mirrored that of grade 2 midwives in the biomedical sector, right? And so they have these uniform trainings, they have rules that they had to abide by. And then the various CAC churches, the fairly large CAC churches, had to have a faith home connected to the church. And these faith homes would have a midwife and 1 or 2 midwives assistants. So that kind of imposed some oversight and some structure over this practice. And by the 80s and 90s, we begin to see more attention to training, refresher courses too. So it's not just about training the midwives and pushing them out to the faith homes where they could practice. Every year, it became a mandate that every year the midwives returned to the location of the midwifery training school in Ede. They returned there for their refresher course, a refresher course. And in the 90s and throughout up to date, we see a partnership in these trainings, in these refresher courses, where government officials, government is invited, government health workers are invited, doctors are present, and they assist, they facilitate some of the workshops, and they assist in the training of these midwives and in the refresher courses. Now, the most significant shift that's happened in terms of change is the establishment of a referral system. Right. It did not exist prior to the 1990s, but by this period, there was a clear recognition that there are circumstances that may be beyond the control of the midwives and the faith homes. And it's very important to note that the leaders of the faith home training center, the midwifery school, were biomedically trained midwives and also faith home midwives. So these were well-educated women who had training as nurses and who became the matrons of the faith home. So they are also bringing their knowledge and their insights to bear in the running of these facilities and in the ways that things are done. And it was them who spearheaded a lot of these partnerships, especially the referral network, because then in the 90s, they were trying to protect their establishment, and they were trying to make sure that their name, as we would say, is not spoiled. That people do not die on the routine in their facilities, and then it becomes a bad name for them. So they instituted a mandate for the midwives that became a standard practice, that every faith home had to have a hospital that they can refer to. So sometimes they formed partnerships with friendly doctors. There were doctors in the ranks of CAC members. There were nurses there. There were all kinds of professionals there. There are professors in there. So they formed partnerships with doctors that were friendly to their cause, the idea of prayers and the idea of faith healing. And so when complications arose, they would then refer to those hospitals. And they didn't just send the women away to go to the hospitals. In many cases, the midwife or the midwife's assistant accompanied the woman to the hospital. And as soon as they see her, they know what is going on. They know that this is a referral. And then that woman is attended to probably quicker than she would have been if she just randomly walked in there in a late stage of her pregnancy or in the course of labor. So these are some of the changes that's happened, and these are some of the partnerships that have formed. And because of this, well, I wouldn't say because of the partnership, because those CAC faith homes have been keeping detailed records, but these records become even more important now that there's a referral system where they record the conditions of women during their pregnancy, in the course of labor, in the course of delivery. They even check when the first stage of labor starts, when the second stage of labor starts. So these are women with training, women that actually are aware of what is going on biologically, anatomically in the course of a pregnancy and delivery. And these records then come into play when they need to refer. And they immediately move the records to the hospitals. And again, this specifically applies to CAC faith homes, because there are faith homes all over the country that do not have the same level of organization or sophistication or the same level of belief or changes that I am describing here. And of course, the idea of hygiene and nutrition has always been present. It still is present, but it was even more so present before independence, in the early days of Christ Apostolic Church and their faith homes, when the major founder, Joseph Babalola, preached hygiene as it was a big emphasis, as one of the things to pay attention to during pregnancy. And his teaching was that a dirty kitchen was the highway to the grave. So that it was important for pregnant women to demonstrate good hygiene, to practice good hygiene and nutrition. He emphasized nutrition, and the midwives, a lot of the midwives today till date, emphasized nutrition as well. So it wasn't just about prayers and psalms. It was also an emphasis on hygiene and on nutrition for a healthy outcome during pregnancy.
Oh my, that demonstrates great willingness to develop and change and improve for the good of the population and service users. I'm not sure how much this ability to evolve is recognized by a variety of individuals who analyze the healthcare systems back home in Africa. And perhaps we could discuss this later, but then they use terms like traditional and unorthodox medicine or practice and things like that. And the kind of usage is a very broad category that actually includes some of these faith homes, as you described them, without recognizing just how much, they could be as good as these other hospitals that are described as orthodox.
No, I agree. I totally agree. And that's one of the things that we have to reflect on when we talk about decolonization, when we talk about creating a system that reflects the realities in our various communities.
Yes. You've mentioned decolonization, but I'm just going to come back to that briefly, because that's actually a very important topic for us as well. And I'm aware you have another meeting you need to attend. But there's something you said in the book as well that I'm very much interested in just discussing very briefly. So you did say that women have had a preference for the faith homes over this other state-based, and a variety of other private medical service providers when it comes to maternity services. Um, I think you've already mentioned some of the factors which might have led to this, but would you like to talk about this very briefly?
Okay. Yeah, absolutely. The reason why women prefer or those who use faith homes navigate to faith homes. In the early periods of the faith homes, well, in the early post-colonial period, the 60s, 70s, 80s, it was in many ways an economic reason, an economic rationale. Now, in the 1980s, anyone who understands world history and Nigerian history in particular would remember that in the late 70s and 1980s, Nigeria slipped into an economic depression. There's a lot of conversations about that. Money becomes scarce. And these faith homes operated free of charge. A lot of them still do. Some charge some fees, some charge token fees. So a woman, at least in the contemporary period, a woman is required to pay for her registration card. She registers, and then she shows up every week for her prenatal, every 2 weeks for her prenatal care, and every week for her prayer sessions. When at the onset of labor or by 7 months, she produces a list, the items in a list given to her by the faith home midwife. At the end of the delivery, her family, she or her family, they give the midwife a token, whatever they can. So whatever comes out of their heart, or that they can afford, they give to the midwives. But in the hospitals, well, you have to pay. And in many cases, you pay, you do not get service. And you pay a deposit and you do get service, and you do not pay the balance, then you are not released. So
Absolutely.
a lot of people gravitated towards the faith homes because it was an economic decision. It was more affordable for them. But there's also a question of access, especially when we go back to the 40s, the 50s, and even the 60s. In the course of my interviews, I talked to people who recounted, for instance, in the 50s, a man that I was interviewing recounted how his mother had a baby with a prophet. And he said in his city, around Ibadan, in his city, there were only 2 government hospitals. And those 2 government hospitals were far.
Yeah.
And so when the mother goes into labor, that faith clinic somewhere was the closest thing they could find. And they took the woman there, and she had her baby. They ministered to her, prayers, care, attention, and she delivered. So there's the issue of access. And someone else describes in the 1990s when her mother goes into labor as well. And the closest facility that they could get to was a faith home. And so they have their baby in that faith home. There was a protest too. This was in Lagos. There was a protest too going on. So the hospitals were closed down. So we have to think about it in terms of access, in terms of economic capability. The fact that the hospitals are expensive, were and are expensive for a lot of families, a lot of these women. And also the fact that there are not enough biomedical facilities in a lot of these areas.
Yes.
And then on the other end, there are women who have described the poor conditions that they experience in the hospital settings. If you look at newspapers in the 80s, you're going to see a lot of headlines and a lot of discussions on overcrowding in government hospitals. The conditions were not ideal at all. And in my interviews, in my oral histories, I see the same thing play out time and time again in my interviews, where women describe overcrowding, spending an entire day in a hospital without getting care, being exposed to indecencies, because There are no rooms. They're on the floor. There's no privacy. Also, being verbally abused. This was a theme that came up a lot from a lot of interviewees, how they were verbally abused by healthcare workers. And so for a lot of the women, they were not going to subject themselves to that. And one of the women said to me, when I get to the faith home, the first question that the midwife asks me is, have I eaten? And they actually provide food for those who say they haven't eaten. So it is these kinds of attention, these kinds of emotional nurturing and care, and these kinds of listening, like someone who listens to them, who it's not just about bringing them in, writing on the chart and pushing them out, and talking down at them if they complain that something was wrong, and abusing them, saying things like, did I get you pregnant? Or when you were doing it, you did not know. Things like that. So there are reports about things like that. And so some women choose to go to the faith homes because of the kinds of treatments that they get in those faith homes. And then there are those who have had negative outcomes in the hospitals previously.
Right.
And these are usually outcomes that are preventable, like negative outcomes that are preventable. It is the loss of a child during delivery. In many cases, it's also the loss of a sister, a friend in a hospital, a death that to them did not make sense, should not have happened. So during their next delivery, they go to the faith home because they believe that the hospital would not work for them, that something would go wrong in the hospital, that their baby died in the hospital. In fact, one of my interviewees said to me that the only baby, they had 4 kids, the only child that died was the one that they had in the hospital. And so for the other ones, they stuck with the faith homes. So there are narratives like that. And then there are those who go to those spaces because they believe there's a spiritual issue associated with their pregnancy. Nigeria and most of Africa are cultures that believe in the diverse causality of illness. The fact that circumstances can have physical causes, natural causes, spiritual causes. There's the belief in the evil eye, or there are those who have had what the Yoruba describe as abiku, and Igbo describe as obanje. Spirit children, born to die children, they call them. Children that the belief that you give birth to this child, it dies shortly after birth, and then it comes back again, and the same cycle keeps repeating itself. Those people with those history navigate to the spiritual spaces. They go to the faith homes because of the spiritual attention component of care. And even in some cases, when they end up not delivering in the faith homes, they go to the faith homes for their prenatal care, show up in the hospital occasionally so the hospital can still take their delivery, and then they can deliver in the hospital. Or they go to the faith homes throughout that pregnancy and they deliver in the faith homes because of, again, the kinds of protection that they needed and they believed that they would get if they had their baby in those spiritually focused spaces. And then there's the women who believe, and families that believe in faith healing, whose spiritual belief entails that they do not rely on medicine, traditional or biomedicine. And so these women, when it's time to deliver, these women seek out the faith homes. They are not even when it's time to deliver, because the faith homes require, at least the CAC faith homes require, that you register with them at no later than 5 months, the 5th month of your pregnancy, and that you attend every prayer meeting. Because if you did not attend, then they believe that you are unpredictable. They have not addressed the spiritual dimensions of your pregnancy and your care enough, and anything can happen when it's the date for delivery. So these are some of the various reasons that women navigate to these spaces. It is not one single reason.
Yes, I can see that very clearly. Uh, I'm just thinking as well about, I mean, given the reasons you've mentioned, I'm thinking about how the Nigerian state, I mean, Nigerian authorities particularly, should deal with fed homes. Like, should there be concerned with the preference that women have for the fed homes, or should they instead consider the fed homes as potential partners, or should they perhaps see the fed homes as rivals? What should be the very appropriate and perhaps the most helpful approach for the Nigerian authorities to adopt, also given the weaknesses of the Nigerian state? So it's just not able to provide very sufficiently the kind of medical service that our Nigerian women require. So if we had some listeners who perhaps are part of the Nigerian Health Ministry, and they would be listening to find out what would be the best course of action for the Nigerian. I mean, I recognize already, as you said, there's some partnership happening in parts of the country between the FETOMs and the government, but at subnational and national levels. But are there other recommendations you want to add just before we think about decolonization? And then you can attend that meeting.
I think that partnership
Yeah,
is the only way.
right.
Government should be concerned,
Mm,
but they should also pursue full-on partnership. Concerned because uh, we should all recognize that there are facilities and there are faith homes and all kinds of other providers that do not think about care in a comprehensive manner, that perhaps do not recognize even the danger signs of pregnancy.
mm,
But outside of that, partnership is the only way forward in this case, due to the reason, one of the reasons that you mentioned. Nigeria is a country of over 200 million people. The ratio of doctors to that population is very poor. The
yes.
number of facilities, healthcare facilities that we have, this also doesn't serve the population. It's not adequate to serve the population that it's
Mm,
supposed to serve. The conditions of the primary healthcare facilities is quite interesting. When you look at pictures of these facilities, it is interesting what goes on there and the kinds of conditions that the healthcare workers in those settings operate on.
mm,
And then there's the faith homes. For instance, again, referring back to everything that I've described about CAC faith homes. Those faith homes are not going anywhere.
yes.
They serve a significant part of the population, especially in Western Nigeria. And women keep going to them,
Mm,
right? If women were not going to them, if they were not viewed favorably, they would be out of business. They
absolutely.
wouldn't exist. And so, what do you do in that case? In that case, then, to strengthen, if we center women at the heart of the conversation, then the conversation should be around the kind of care, the kind of system we can create
Mm,
to provide stronger healthcare services, stronger maternity services for women. And this is where we can then form partnerships with the institutions that currently exist,
mm,
including faith homes, for example. Government cannot ignore them because then it's risky
yes,
health-wise. It's
exactly.
comes to women's health because then you're cutting off a significant number of care providers, whether we like them or not. They still provide care for
Mm,
women. Now, CAC has a structure that works for them, has a system. But how about the other faith homes that are just small independent faith homes scattered all over?
Exactly.
So if we have to bring them to the table, government has to bring them to the table, make them part of whatever conversations they are having around maternal health care. When they become part of the conversation, then they can also implement whatever government wants to implement in terms of women's health.
Mm.
When they are not part of that conversation, then they continue to do whatever they want to do, and government continues to talk about whatever it wants to talk about.
Yeah.
And so implementation becomes a problem.
Mm.
Now, in the Nigerian space, we also know that religion and religious institutions are powerful institutions.
Mm.
They are powerful in the sense that they are good places to shape public opinion. People listen to their pastors.
Yes.
People listen to their religious institutions. People listen to their imams, whoever their religious authority figures are. So if there is a partnership when it comes to maternal health care, then the government will also be reaching a significant part of the population. Their messaging will be carried by this institution if they get these institutions to buy into those messaging. If they make policies and if they make decisions that these various stakeholders are part of. And then we will be providing care to more Nigerian women, or quality care to more Nigerian women than previously. It is already established that the biomedical infrastructure and the biomedical institution in Nigeria is incapable of providing care to women, to Nigerian citizens in general. So it is time to think about strengthening the systems that we have, looking at the weaknesses in those systems, addressing those weaknesses, bringing those stakeholders to the table, and working together to provide better care for women. So partnership is the only way out. Like, there's no way out other than partnership, because medical pluralism, the belief in seeking multiple forms of care, multiple forms of therapies at the same time, be it the spiritual one, the traditional one, or the hospitals, it's not going anywhere. It's a matter of survival for Nigerians. And so that's not going anywhere. Women are going to continue to use traditional midwives. They're going to continue to use faith home midwives, and they're going to continue to use the hospitals. So how do we strengthen what we have, what exists, in a way that it actually serves women, as opposed to our own ideas of what should be? That's the biggest thing that I would say. Partnership. And CAC is a good example. The CAC Faith Homes is a good example of what this could look like when they do their refresher courses. But this is them seeking out these partnerships. They invite government health workers and doctors, because they want to stay aware from year to year of the changes in maternal health care, of some of the newer techniques, of some of the new knowledge that they should be aware of. Even some of them have embraced the use of vitamins, prenatal and other vitamins, iron, for instance, to improve the health of pregnant women, right? They have established referral networks. And this referral network, I saw it play out during one of my interviews, where a woman shows up the day before. She had, it was just for the prayer session. It wasn't a prenatal day for the prenatal care. But the midwife checks her blood pressure. Her blood pressure is high. The following day, she shows up for her prenatal care, and the midwife checks her blood pressure, which she has a record of. She records it, and it was significantly high. She immediately said, "Look, you have a high blood pressure. You were arguing, fighting with another woman just outside, and you're about to give birth and everything. You have a high blood pressure. You're going to the hospital right now." So she immediately dispatches her to the hospital, because she recognizes that to have pressures that high close to delivery was dangerous.
Very dangerous, yes.
It may not just be pre-eclampsia, it could be eclampsia, which would cause seizure and death within minutes. So
Yes.
now, if we have a system of partnership and of training, collaboration like this,
Monitoring.
then these various individuals become a tool
Mm.
for flagging risks like that. If this
Mm.
woman wasn't going to the faith home and wasn't mandated to show up for her the prayer session, and then she has to show up for her prenatal care, that high blood pressure could have easily been missed. She could have
Absolutely.
easily went into seizure at home and
Lost
died,
a life,
or
yes.
she would have gone into labor and went into pre-eclampsia, and then eclampsia could kick in and you lose mother and baby. So we have to think about these kinds of partnerships, these kinds of collaborations. It can only strengthen the system. If anything, they become primary health caregivers that can flag and then refer to, that can flag issues early on, because they have constant contact with these women. They
Yes,
treat the
yes.
women better. They are not as overcrowded and as overworked as the healthcare workers in the hospitals. They could flag the dangerous cases and immediately send them to the hospitals. But there has to be a partnership for that to happen. Imagine the CAC referral network not existing with hospitals that are interested in partnering with them. Imagine a woman going from a faith home to a hospital at 8 or 9 months pregnant. You can guess that it's highly likely that she would not find care. And so by
Absolutely,
the
yes.
time she finds a facility that could treat her, she may be dead. Like, these complications can escalate quickly. So these are some of the things that I think we can increasingly think about, and I hope that the government can increasingly think about too. I know that over the past a couple of years, because I was doing some research at the Ministry of Health, Federal Ministry of Health, a lot more partnership is going on. There's conversations going on, but I hope that they actually think about it some more, and state ministries of health to think about these kinds of partnerships as ways to regulate, to strengthen, to train in a way that is mutually beneficial to all
Yes.
parties.
Thank you, Dr. Williams. I would actually like to spend some more time personally thinking about how to get some of the episodes here on Africa Simplified to the key actors in the Nigerian political space. This is something I need to think very much about, not just at the federal level, but also at the very local level, and as well at the state level, as we call them in Nigeria. So this is something I need to discuss very extensively, because this kind of suggestion, as you've presented it, isn't coming from nowhere. It's coming from extensive research that you've conducted. So I think it is what they should pay very great attention to it and act with this information that you've given us as well. You've already talked about decolonization, and I think in the last few comments that you made, you've also perhaps responded to the question that I was about to ask. But just to say that in the 5th chapter of your book, you cited Joseph Ojo Mume, who actually wrote a text, a book that was called Tradomedicalism. What is it? And it was published in the 1970s, 1974.
Thereabouts.
Exactly. So I'm just going to take a very short time to go through what you quoted, and just to find out if there are other thoughts you might like to share about what we can learn from the Nigerian medical space about decolonization, not just us as scholars, but also a variety of other policymakers and policy implementers. So Joseph Mume actually said that for too long, Africans had accepted definitions of being civilized that did not arise from their own cultures, but which had been imposed on them. And the present medical system is a colonial legacy which is unsuitable for the Africans. And my suggestion, that is his suggestion, is that we should create a forum where medical and tradomedical doctors can meet to decide what will be the pattern of medical system whose universality will not be prejudiced. And the view that he takes is that Africans can master modern and Western technology without abandoning their cultural heritage. And you spend some time in that chapter building on this idea. And you've already actually discussed this in the course of this conversation. But are there other final thoughts you want to share just before we finish? What is it we can learn about decolonization from the Nigerian health sector?
I think Mume's quote captures a lot that can be said. We have to revise our views of traditional medicine in general, or what we consider alternative medicine. Now, how do you define traditional medicine? Earlier on, I talked about the various components of traditional medicine practice: the bone setters, the herbalists, the diviners, the midwives, and gynecologists. There are layers of components to this. But one of the things that colonialism did was to teach us that everything African was bad, including our names, the ways that we got married, our music. Like, these are, when you look at colonial records, these are conversations that were being had. To become a Christian was to adopt Westernization and Western culture. To become civilized, quote and unquote, was to do the same thing.
Yes.
So everything African was viewed as backwards, as uncivilized, as not worth anything. We have to begin to think about our systems, to think about what is valuable in our practices. Today in China, for example, acupuncture has become this worldwide thing that people, even in the West, adopt.
Yes.
In India, Ayurveda, it's the same thing. So we have to think about what in African medicine, traditional medicine has a wide variety of pharmacopoeia, for instance, pharmaceuticals, herbs. And these herbs have enriched Western medicine and Western cultures. Throughout the colonial period, a lot of these herbs were taken away to Europe.
Yes. Yes.
The active ingredients, the active properties in those herbs that were being produced by the traditional doctors were identified, and it was turned into tablets and sold back to Africa and the rest of the world. But the main thing that generated that medicine is an abundance in these various African countries, including Nigeria. I can go on and on about stories from the archives, from colonial records, about thefts that happen with herbal medicines, including false arrests of traditional doctors to get hands on their traditional medicines, their mixtures, or what they would call their concoctions, to figure out what is active in there that could be of use, of benefit. So these are things that we have to think about. Because the moment, if we continue to think about have this blanket view of traditional medicine as backwards, as negative, as unrefined, then we can't go anywhere when it comes to medicine and medical care. We cannot advance if we don't begin to take our indigenous knowledge systems seriously and think about what works, what should be thrown away forever. Some things are what thrown away forever. But there are a lot of things that should be hugged and embraced and developed, right? We have to think about it. And the reason I say we have to revise our view of traditional medicine is because of the partnership points that I made previously. Conversations around these partnerships come from a place typical of the colonial experience, a place of biomedical supremacy.
Right.
A place of devaluation of every other medicines that's now considered alternative medicine. And when we come from that angle, we cannot have any productive conversations.
No.
I've been in a room recently, this year, where a nurse midwife says that traditional midwives, they should not be called midwives. They are not midwives. They are quacks. Nobody should call them midwives. So the question, someone then asked the question, so what are they?
Exactly.
Before biomedicine became a thing and biomedical midwifery started to expand as recent as the 1940s and 1950s, and I say recent deliberately because that's not ancient history. Women were having babies. Fertility care, reproductive care was being enforced. So imagine then bringing this person to a table with these midwives, right? Or with other practitioners, kind of practitioners that were non-biomedical. You can imagine what the kind of conversation would be. It would come from a place of disrespect,
Yes.
a place of hierarchy and supremacy and devalue versus value. So that is why we have to rethink our attitude, the way that we frame other medical traditions and other medical cultures, and the way that, so that we can forge a partnership that works, so that we can bring others to the table and actually discuss a system that works for us, for our own local realities, because each system has its own realities. The realities in England cannot work, or the solutions for the realities in England cannot work in a Nigerian setting, right? And we have had more than 60 years of examples of how that cannot work. So it is time to kind of rethink and reapproach. And I also think in conversations about decolonization of the health sector, and when we talk about women, we have to recenter women in the narrative. The outcome of that narrative will be different if we actually center women in the conversation. They are the ones seeking care. They are the ones whose bodies are being subjected to care. Why don't we center them? Start the narrative from them. Figure out what they need, what they use, what they gravitate to, and then answer the questions from there, as opposed to centering other things. Centering access, centering what is legitimate, centering status, censoring feelings, or different things. There are different things that are being centered, but not women. Everything but women. So if we center women in the conversations of decolonizing healthcare, of maternal healthcare, then we're going to have a different kind of narrative. That's I think I will stop here, and I can follow up on anything else that you want to follow up on.
There's nothing else, to be honest. I think this is a good point to conclude with, that the future will be more positive for women and, of course, the entire population, if women are centered more sustainably in the conversations about the health of women. That is actually a very important point. And I'm hoping that we would continue this conversation subsequently, because I understand we've used up the time that we have. But I think we've discussed some of the most important issues today, especially those which your book very excellently discussed, but also those which I think the Nigerian authorities who would forward this to, or highlight some of the points from the conversations to, would find very relevant in terms of policy making and implementation, given the current maternity health crisis in that part of the world. So I think this has been wonderful. And I don't have other, I mean, of course, I have other questions, but I think this is a good point to conclude. And then perhaps we should plan to do this again. What do you think about doing this again sometime?
Well, let me know.
Yeah, maybe on your next book, actually, maternity deaths. I think we might do that one for that. And then I have to book well in advance, of course.
No problem.
Okay. Well, thanks everyone for listening today. And please share your comments or other questions. I'm very sure that Dr. Williams will be very pleased to respond to this, of course, outside this conversation. So thanks again for joining us, Dr. Williams, and we
Thank
look
you.
forward to seeing you again.
All right. Thank you very much.
Okay, bye-bye.
All right. Bye.